Hello. Hello. 10.5 years old female child, first by birth order, hailing from Bihar, resident of Mankut, presented with complaints of cough, cold for 3 days, 15 days back, fever since 7 days, altered behavior since 6 days, and multiple episodes of paroxysmal events since last 7 days. Child was alright 15 to 20 days back when she developed cough and cold. Cough was dry, intermittent, non-spasmodic, associated with cold. Fever was continuous with documented spikes of 38 degrees Celsius. In referring hospital, not relieved completely with medication. One day after the onset of fever, child had altered sensorium in form of speaking gibberish and not recognizing parents, disturbed sleep pattern and irritability. First episode of seizure occurred on 1st of May around 7:30 a.m. in form of left-sided deviation of mouth and jerky movements of left upper and lower limb associated with frothing from mouth with twitching movements of mouth and eyes lasting for approximately 1 hour. Uh, Presented to the referring hospital emergency in active seizure which resolves on IV medication. Course at referral hospital. Uh, on first day, child was started on some anti-seizure medication and some lab investigation was done for fever which was told to normal. On day 2 of admission, the child had similar episode of seizure uh, and then started on second anti-seizure medication. Lumbar puncture was done and IV medications continued. On day 3, child had 3 episodes of seizure of similar semiology. On day 4 of admission, child was drowsy. Some neuroimaging was done, and altered sensorium was persistent in form of abnormal talk and not recognizing parents. Every day, in the course of 7 days, every day, child had 2 to 3 episodes of seizure, and child was referred to our hospital for further management. Course at our hospital, same anti-seizure medication was continued, and child had episode of seizure on day 2 of admission in our hospital. In course of last 5 to 6 days, there was no repeat episode of seizure. Child has altered sensorium and abnormal talk in episodic manner, which has no pattern and no aggravating factors.
Anything else? Past history, nothing. So this you have said fever since 7 days is with respect to our hospital.
Child was admitted on 7th of Child was admitted on 7th of May.
So don't give us dates. Give us the day of onset of complaints and in relation to that, the first admission and all that.
If we means last 15 to 20 days, child had onset.
See, what I'm saying is, in the exam, you can't mix up the illness and the dates. You've given us admitted here on first. But when did the illness start? You have not given the date. So you should say 15 days back cough and cold, 7 days back fever, 6 days back admitted to the outside hospital, something like that. You understood? So after how many days of fever that altered sensorium came in?
1 day after.
Immediately. And then that day he was admitted, right?
That day, altered sensorium followed by seizure. Then that day, the day of seizure, the child was admitted in
Fine,
referring on.
fine. So what do you all think of this story? So cough and cold 15 days back, and then fever they are saying since 7 days. And next day of the fever, change in sensorium. What do you think? Let's start with very simple things. Infection or no infection? Can be infection. What is the anatomy of the infection? Means which part, brain or extra CNS? Started with cough and cold.
Has to be frontal because there is history of focal seizure.
Frontal, we will talk of later. That is within the CNS. What I am saying is, what I am asking is to put it very, started with cough and cold. So, do you think this is a respiratory problem, like let's say a pneumonia or a viral pneumonia, who has then become hypoxic and then got seizure? Is that a possibility, or this is a primary CNS infection? Anyone? We are just thinking and learning. There's
Could be
nothing.
primary CNS,
Okay, why?
because just one day, within one day of fever, the child had altered behavior.
Okay. So within the CNS, it has progressed very fast. Now, to call it respiratory and then secondary CNS, are there any problems? Good. I'm just making you think. Suppose I am arguing that this is a viral interstitial pneumonia and then he became hypoxic. And that's why I got all the CNS problems.
The condition during those period, cough cold 15 days, back for 3 days, then fever 7 days. In between, how was he? That
Okay. And what else? So always think like this. When I am saying it was a pneumonia first, so there has to be a stage of pneumonia. At that stage, what would the child have? What will be the complaints of the child? Breathlessness, no. So there has to be breathlessness for the child to become hypoxic and then CNS. There is no such history, right? So it is not a respiratory problem which has gone to the CNS. It is a primary CNS infection only, right?
I think the most important part is the deterioration CNS-wise has come up within 24 hours of fever. Which infection are we talking about when somebody within 24 hours gets a fastly progressive CNS deterioration? You said it's an infection. Why? Because there was fever. Now, he's an older child. Do you think it's a bacterial meningitis? No. Why do you say no? So talk about it. Let's systematically understand the whole process. You are right.
groups. Usually, infancy and we will get bacterial pyogenic in the adolescent age groups.
A bacterial meningitis at that age is not an encephalitis. Encephalon is not involved in bacterial meningitis at 10 years of age, unless you have fired your diagnosis and management. The story starts with headache, vomiting, irritability, high fever, goes on and on. And there is hardly any brain cell involvement. It's only the meninges. But give me a newborn or a young infant, yes, that meningitis suddenly becomes also encephalon involvement. Do you think infection has traveled fast from meninges to brain cell? And in an older child, it doesn't go that fast. And the answer is no, it's not infection, but because
कौन है ललित जैनाचा तो आप डिटेल्स पढ़े
With acute bacterial meningitis, raised ICT makes a brain cell edematous, and then they start encephalopathy. In young infants, this process becomes very fast. In an older child, it is almost not seen unless they don't go to a doctor or doctor doesn't. It's not likely. So this is not a bacterial infection. Could it be tuberculous meningoencephalitis? One disease which starts as meningitis and encephalitis both. And therefore, we have said it again and again. Your story starts telling us how well he was prior to onset of this disease. Now, if I know that he was always sick, whatever sickness, my whole discussion is different. And if you say, no, he was a very healthy child, then the probabilities are different. So bacterial infection is out. Okay. Now that cold and cough was without fever, right? And in between there was nothing. Why are you trying to push two together? What way you can connect two together? Cold and cough, probably viral infection. Okay, but there's no fever. We will still consider it as bacterial viral infection for our discussion. But why should an older child not get fever, cold, cough? There's only cold and cough. But let's believe it's a viral infection. Can viral infection settle down and a week later develops a CNS complications? Can that happen?
Come on, think.
Don't give a thought.
There are many CNS problems where you say no history of viral infection.
No history of vaccination.
Autoimmune.
Excellent. So not autoimmune, but infection-induced immune. You are right. By autoimmune, we mean no trigger at all, some way the immune system just behaves abnormally. But you are right. And do you think autoimmune will take a long time between the two or just a short time? For example, GBS is autoimmune, ITP is autoimmune. Okay. What is your idea about the interval between a triggering viral infection and a complication?
2 to 4 weeks, he's saying.
Excellent. Excellent. And therefore, today we know that after COVID, we have realized that it could take even 6 months or a year to come out with some organ complication like heart or whatever. But that's not important for us in pediatric practice. So it could happen within a short time or within a little long time, as you said, 4 to 6 weeks. Typical rheumatic fever takes 2 weeks. So we know that. So that could be possible. Do you think that could be the cause of this being an autoimmune encephalitis? Bacterial infection is out. Okay. Give a thought, because any one of us can be right or wrong. At the end of 60 years of pediatrics, I am often wrong.
So
It's a shame.
you said in the beginning could be infection, which means you are also thinking of something else, which probably is this. So do you think both are possible or you are strongly on one or the other, or can we differentiate? Any thoughts?
So the seizure which is mentioned subsequently is focal. Had it been autoimmune, the presentation would have been generalized.
Why do you say focal? So whole left side, right? So large focal. So is there anything large focal that whole half side is involved? Give a thought. Okay, it's interesting. By focal, we mean small area somewhere.
So let's take a diversion. What is the meaning of a focal seizure? What is our concept of a focal seizure? Both in terms of what is happening in the brain and what is happening clinically. Come on. We are all learning. Let's learn together.
Only one limb will be usually involved, sir, and we can localize the lesion to
Not
one
necessarily
part of the
one part of the body
scene.
rather than limb. And often there is likely to be
a partial onset of focality when it is generalized. It started with and then it generalized. So focality is often diagnosed from the onset. He says right side cophidia. Wait, how did it start? Did it start all of a sudden from right side? Often no. It started with the hand and then it's so anytime in focal, always see there has to be an onset which is focal and then it could be secondary generalized. So focal or non-focal. This was focal. We don't know whether it all started on the right side and it was focal. Coming back to the first cold cough, was it really the parents have complained that it was cold cough or just cold means runny nose and cough? Was it a significant illness that we should pay attention to? Because we are discussing the immunological complications.
Only minimal symptoms were there, mild cough and cough.
She herself said, पहले खांसी सर्दी 2-3 दिन आया, फिर 2-4 दिन अच्छे गए. Yeah, you said क्या हुआ? And they said,
Initially, she started history with fever. Then after that, she said कि 7 days back there was.
so if she said fever, then we have to mention here fever and cough cold. So there was an infection and there was a long.
No. She's saying that when you asked her kya hua, she started with this history of 7 days back. She did not mention the cough and cold.
So how did you come to that cough and cold? By repeated asking or क्या हुआ सर्दी खांसी हुआ था क्या? हाँ हुआ था.
I asked कि उसके पहले भी कभी बुखार आया था क्या और कुछ complaints थी तो she said cough and cold.
So we take it either way. Maybe that cough and cold was significant, maybe not. If it was significant and if we are entertaining an immunologically disease, then maybe the interval it can be variable, 7 days, 14 days also. But then I was thinking that after the onset of fever on within day, the disease progressed very fast from altered sensorium to a seizure. But somehow the progress there has, after that has not been so. The child had fever, focal fever within 24 hours of onset of the neurological complication, rapid. But that rapidity has not gone further like that. The seizures were well controlled or reasonably well controlled, but or they suppose they were not well controlled, but other neurological manifestations have not progressed. He has not been unconscious, very down.
Sir, he's
Other side,
got seizures every day and he's been altered only all along.
but is he conscious and talking, muttering, or
Abnormal talk. Child was talking abnormally.
but
मतलब
he's not unconscious.
she was able to tell her name, but she was not able to tell she is in hospital. मतलब recognize her mother and
Some partial. I thought first progress was too rapid. With that rapidity of illness, she should have gone down further, though we were able to control the seizures. So immunological process which have gone so fast should have perhaps continued little faster in the absence of treatment. Then the others say primarily it was a viral illness. That cough cold we may not have anything to do. Cough cold, and can a viral illness go on so fast within 1 day to the from 1 day of onset fever to the neurological complication? To my mind, I may not say so. I thought the duration should have been little longer. Primary illness, little 1 or 2, then focal seizure. So the rapidity in 1 day probably suggests an immunological, and the time also suggests that it was not so rapid. One does not know. But even then, in the absence of very persistent, very high fever, if it was a primary viral, which it was not so perhaps, I would still entertain between the two.
What happened to the fever afterwards?
child is still spiking daily, 1 to 2 fever spike.
Oh, that means the viral illness, if it is there, then it is difficult to determine which one. I have to guess between one of the two. I would perhaps think that initial viral fever of 5 was not so important, and this is primarily an infection, viral and not immunological, involving central nervous system.
I think the reason why the fever is continued indicates that it is less likely autoimmune or infection-induced immune. Generally, the fever is just a trigger, and then the immune system fires. Here, the fever is continuous. So that is one reason that we must call it as some infection. If you talk about viral infection, then that cold and cough has nothing to do with this. And this is a fresh acute viral encephalitis, which is a possibility. But the other possibilities is it some unusual organisms that we are talking about? We have not looked at any other unusual organism. For example, could it be cerebral malaria? What do you think about it being cerebral malaria? See, because even if viral encephalitis continuing like this for 6-7 days is not usual. Most of the viral encephalitis go down very fast, or at least the fever disappears, the damage continues. This fever is going on and on. But yes, infections can go on causing fever, so we keep that in mind. But that puts me to feel that are we looking at some unusual infections? Not usual bacteria, not usual tubercle. So one thought, I thought, could it be cerebral malaria?
Any thoughts on that? Does the fever look like malaria to you?
So fever is still on, no? And this fever is not likely malaria. Okay. But keep in mind cerebral malaria as one complication of infection affair. Often cerebral malaria causes of localized disease. Because why does an encephalopathy occur in malaria? Because the parasites clog the blood vessel. So possibly you have a focal vascular lesions coming up. Of course, then there are multiple, then it can have an encephalopathy. Could it be any other kind of unusual infections? Okay. Many of them can cause also such neurological complication. Could it be rickettsia? Could it be leptospira? Could it be EB virus, which goes on for a long time? What are your thoughts? Nobody can tell us which organism this is, and even the bacteriology and virology may fail. So we know the limitations of clinicians, but let's give a thought to all that.
As a concept, just as a thought process, as a concept to learn. So suppose we ask you the other way around. Suppose we ask you, how will a rickettsia present?
Yeah.
What will you say? How will a child with rickettsial fever present to us? What will be your description? Okay, petechial rash. Of course, first of all, fever. Then, what else?
Long duration of fever.
Very good. So, for most of these other infections, rickettsial, leptospira, whatever, fever will be for a few days. And then you may have a CNS, not on day 1, day 2.
For example, I remember the picture of malaria. High fever just not coming down. On 4th, 5th day, they get problem. When malaria just does, otherwise you expect episodic malaria. When malaria, yes, but just not coming down, expect that this child is going in for complications. But day 1 presenting as cerebral malaria, no, or any infection, the illness is too short. आज शुरू हुआ कल CNS.
Could it be any metabolic encephalopathy? Because what triggers off is immune, but what triggers off is also metabolic. Or, of course, the same infection is causing that. 3 types of neurological disorders. You think it could be metabolic? Give a thought.
There is a genetic entity called febrile seizure plus, which can present in this age group with similar presentation.
Very good. Which metabolic at 10 years of age? Give a thought. Which metabolic?
He's saying febrile seizure plus. But febrile
Yeah.
seizure plus should have febrile
Yeah.
seizures at
Yeah.
that
Yeah.
time. Past history. And then they will come with
Yeah.
all this. Right?
And
At a
that's
later-
not metabolic. Okay.
genetic.
So at 10.5 years, metabolic is unusual. Okay. Most of them present acute insult in early life, and some of them present with hepatosplenomegaly and slowly going down as Gaucher's, Niemann-Pick's, whatever. But this is not the story. So we left behind with viral encephalitis or maybe an immune-mediated encephalopathy. We will not be able to differentiate the two so easily. So would the clinical examination add on any information? What do you think? The type of things that we are discussing, viral encephalitis or autoimmune, what are we looking at? Nothing, some brain damage. Does it tell us the etiology or difference between the two? So do you think physical examination will not add on anything at all? Or if so, what specifically you will look for?
Do autoimmune encephalitis involve some particular area of the brain? More likely. Basal ganglia, very good.
Okay, so we may look that it could even involve the spinal cord. So like ADEM, okay. So many other things we may look at. Could there be a hepatosplenomegaly? Maybe, we don't know. History won't pick us up. So we will know on that, but we may not know much more on physical examination, and we will only see what is the brain damage remaining behind, right?
And progress has also not suggested organ involvement beyond the CNS. There has been persistence of seizure, but any other thing to suggest involvement of liver, jaundice, anuria, oliguria, none of these things are there. So it's primarily CNS. Progress has been rapid first, but that rapidity has not gone beyond that. It has remained only vascular one side. Right-sided hemiplegia might be secondary to the involvement of the blood vessel, producing the typical hemiplegia. You described a typical right-sided hemiplegia, did you not?
No, seizure. Seizure was one
Focal
side.
seizure, but it has restricted to one side and not multiple.
But there is altered sensorium, so therefore,
More than altered, the in viral there is mostly altered sensorium, but more than altered sensorium, she has altered behavior. If she is oriented to time, also she is able to tell her name, but her behavior is very abnormal.
There's a little bit of focality in the CNS also. Some higher centers are maintained, some part is affected, some focality is there.
One type of encephalitis which involves only half side of the brain is called Rasmussen encephalitis. I'm not sure about many more details about it, but that's one which involves only one side of the body, only half the brain is involved. Of course, here it's not half the brain involved. Maybe some hemiparesis light might be seen now on examination, but just keeping in mind, half side of the brain involvement is known in Rasmussen encephalitis.
Dr. Sir was talking of unusual organisms. So mycoplasma is one of them. Dr. Palni Raman said look for rashes and any bullous laryngitis as a sign of mycoplasma.
They should have presented with other systems first rather than coming with CNS. All these things should have come with other manifestation and not jump to CNS right in the beginning.
There was no associated significant history. No previous hospitalization. Antenatal history was uneventful. Birth was normal. Developmentally, child has achieved all age-appropriate milestones. Dietary-wise, calorie deficit of 550 and protein deficit of 5 grams. Family history is not significant. So, on the basis of history, 10 years old girl with acute onset febrile encephalitis with refractory seizures is most likely autoimmune encephalitis, acute viral meningoencephalitis, or febrile infection related epilepsy syndrome.
Or differential.
Because the child is having persistent fever, and according to the definition, the within the onset of febrile illness, 24 to 2 weeks, the child has refractory seizures.
Are the seizures refractory in this
The-
child?
Firstly, the child was started on first AED. Then the daily child used to have 2 to 3 episodes of seizure, which was not, which was requiring 2 to 3 AEDs, and at our hospital, mid as infusion.
So honestly, that is possible even in a viral meningoencephalitis. They can also have very bad seizures. So it is difficult to differentiate clinically, but I don't know, I'm not sure, but I think in fires, the sensorium between two seizures should be poor. Isn't it so? You've read fires?
Yes.
Absolutely, because a typical epilepsy itself means that it's not a continuous, otherwise we'll call it an continuous epileptic. So I think there has to be in between here the patient is unconscious or encephalopathic at least. And what is fires? It fires our understanding, that's all. What are you talking about? Infection. We don't know what infection. Febrile, yes. And then epilepsy, yes. So I'm in short telling you that something has caused infection, maybe fever and epilepsy. But it looks like, and it's a syndrome. So syndrome of negligence and no understanding, and then something together, we call it a syndrome. So I think I understand that when we can't prove anything, we call by such terms, right? Yeah, we agree it's rare, but we are discussing a rare situation. Okay, it doesn't fit in anything, but yes.
On arrival to our hospital, child was conscious but disoriented to time, place, and person. Altered behavior was there. Child was febrile. Heart rate was 116 per minute. RR was 26. Saturation was maintained. BP was 110 to 80. Pulses were well felt. Then
Febrile means what was the degree of temperature? 103, 104, 9900.
around 101, child is daily spiking 101. Anthropometric, child is normal for the age. Weight is 25 kg. Height is 135 centimeter. BM of 13.7. Higher mental functions. Altered behavior was there on cranial nerve examination. The child was not cooperative for third, fourth, and sixth. Rest of the cranial nerve examination was within normal limit. Then motor power was more than 3/5 in all four limbs. Stone was normal. Dependent reflexes were brisk. Plantas were extensors. Meningeal signs was present. Neck rigidity and Koenigs and Budzinski was positive. Child was not cooperative for cerebral signs. And rest of the other systemic examination was within normal limit.
Wait. So what would these signs mean to you? Any interpretation of after examination?
Sir, with in febrile period also there could be the neck rigidity and the reflexes could be brisk. So it is not as a significant enough to, and it does not add any significance to our diagnosis.
Okay. But are you surprised at something after examination? Anything that you noted? Is there any deficit? Is any area involved paralyzed? Any motor deficit? No. So that is just a striking point that we were talking of a viral encephalitis, a neurotropic virus within 1 day fever and seizure and all that, and it is no deficit is a little unusual. I thought there has to be some vascular phenomena. So that was one. And then this meningeal signs. This is odd. So now how do you, so what else? You said it is sometimes seen in fever. So how do you, how in clinical examination, how do you differentiate between true meningeal sign and whether the patient is kind of doing it voluntarily? When you said sometimes fever can do it, it means patient is doing voluntarily. Fever can't do it. So I know there is a situation where we feel there are meningeal signs. Anybody knows how to settle this issue? So you have to take the patient to the edge of the bed as if patient's head from the is falling. Then the patient will automatically go back and this will become supple. It will not be stiff. So that tells you that this is not meningeal. And if there also it remains the same, then it is meningeal.
Meningeal leg signs, etc. Also, sometimes you can put them in prone position and see whether there is back stiffness, neck stiffness, etc.
I think the whole idea of deciding what findings you expect is only to see whether it concurs with what you have seen. And it's not unusual that you don't expect something, but it is there, or vice versa. So I think this meningeal irritation is possibly causing typhoid has meningism. There is no meningitis. Okay. Kawasaki has even inflammation of the meninges. You do a CSF in Kawasaki, you will find some cells. So, if at all, that really an immune mediated. Okay.
Meningeal signs so prominent, but no meningeal symptoms. Of
Exactly.
meningeal
That
irritation.
is why it
That
is
is
not
a-
meningitis.
That is why it's not meningitis. No symptoms of meningitis, but clinically signs of meningitis.
What are the symptoms of meningitis? Very good. So always make it a habit. Don't take all patients as one CNS group. Okay. Separate the headache, vomiting, fever, which is meningitis, from fever and altered sense, which is cortical involvement. You may have both, but in your mind be clear that these are two groups. Okay. Now, I was asking that you've been constantly saying that she's conscious but altered behavior. So that tells you what?
हाँ
Interpretation.
कैफे वन एक मिनट में कल मैं कैफे आपका फूड कैफे बनता बाकी लोगों आणि
Resident इनका ही है सर. So I thought it suggests a frontal lobe involvement, particularly because of so many behavior changes. It's not just a generalized CNS edema or cerebral edema, which you expect in a viral encephalitis, but a selective behavior involvement.
Reticular formation is responsible for level of consciousness. I had no reticular involvement that happens. Not all the portions of the reticular are not involved. As you said, some parts are involved. With the frontal lobe focal seizures also we have to see. The parietal lobe, I would have explained the focal seizure much better than the frontal. That means there is frontal as well as parietal. More extensive involvement that the science may, that we may think of.
One comment is viral is rarely meningoencephalitis. You have often viral encephalitis, but sometimes you may have only viral meningitis without encephalopathy, and that is not rare. And that typically starts with fever, and then a day or two later you find headache coming, but otherwise there is nothing more happening. And to that extent, viral meningitis was also known as aseptic meningitis. And that has a very good prognosis that settles down by itself. So viral meningoencephalitis looks a little unusual, but yes, you have some meningeal signs, so you're putting it as viral meningitis.
Mumps is a good example of viral meningitis.
Yeah,
Often in
actually,
mumps, they can have meningitis, meningeal signs, but there is no encephalitis. It is said that if you do a lumbar puncture, normal cellular reaction in many of them, but there may be no actual clinical. But otherwise, meningitis, yes, encephalitis, no.
had visual hallucinations also, sir. Like she's seeing dinosaur. And even the light is on, she was telling to put on the light, put on the light. And she was having irrelevant talk in the form of like, where is my bachcho and all. She was asking all those things mother was telling.
She was her mother. She is saying her father has to be her husband. Her sibling has to be her kids. That and this was in episodes. Between sometimes she was normal, recognizing her mother, father, everyone. Then after in some episodes she was completely behaving abnormally.
So these are, means how would you, like we earlier said, meningeal symptoms, cortical symptoms, what would you describe all this as? Cortical, yes, but as a group, what would you call it? You call it psychosis. Basically, these are all delusions, hallucinations, all that comes under the broad word psychosis, which also goes towards autoimmune a little more than a viral meningitis, encephalitis. I was talking of fires because you've kept that there. So, what is non-convulsive status? You've heard this term. So what?
Electrical activity will be continuous in the brain, but seizure, convulsions, motor manifestation will be absent.
So, how do you pick it up? And when should you suspect it?
Unexplainable. And there is unexplainable tachycardia. And
Suppose one child has started suddenly behaving abnormally. Is it non-febrile status or non-seizure status? What is a prerequisite for that? When will you suspect that? It is an epileptic patient who has been under treatment, but seizures or epilepsy is partially controlled. The motor phenomenon are absent and only the psychological phenomenon. You can't diagnose it otherwise. So this is a case of epilepsy under treatment, but not continuously seizuring, but abnormal behavior is non-convulsive status. And you will diagnose only one suspect from history and diagnose with EEG. EEG will show you that continuous seizures is there, and you treat the epilepsy, control with better medicine and the behavior. But it has to be an epileptic child on treatment.
So, I mean, when you are putting fires here, that's why I was saying my concept is that you would get a seizure, and the child would be drowsy or sleepy after that, which means you're not sure whether the child is unconscious or what. And then again seizure, and then again seizure. Now, this period in between when the child seems to be in post-ictal drowsiness, but that drowsiness is too long. That is the phase of non-convulsive status. So actually the child is still in a seizure. As you said, there are no motor manifestations. So between two seizures, a sleepy child is when you start suspecting this. Then you notice tachycardia disproportionate to fever is one. But what else? Something which is very important. You have to lift the eyelid of the patient. Patient is sleeping, eyes are closed. You lift the eyelid, you see continuous eye movements. That is a sign that this could be NCS. And then you do the EEG and you get the seizure
So these
going.
children could be walking. One or two cases I saw, the boy was moving about. but incoherent. You are not talking sense. You are not aware of everything. Seizure on treatment. You need not be sleeping and all. We wouldn't suspect very easily unless you know the past history.
Lab investigation was for child. The HB was 12, WBC counts of 6,470, polypredominant, platelet of 1,60,000. This was outside hospital investigations. They have started 3% NSA for the child. So the documented, they have stopped 3% after the sodium was 148, their ammonia was 245, and calcium was 8.1. They have done an CSF with total cells of 50%, 99% lympho, glucose of 105, and protein of 2. There they have started child on for termination of seizure. They have given midas, then lever up to 60 mkd, eptoin up to 20 mkd, valproate up to 30 mkd. They have added acyclovir, piptaz, amikacin, and 3% NSA. Then CT, MRI was suggestive of asymmetrical bilateral altered signal intensity involving subcortical regions of temporoparietal lobes and gyra with swelling. Postictal changes versus acute encephalitis. Fundus was within normal limit. Yes. We have re-reported the MRI from our radiologist. They have interpreted as postictal changes. EG was done, which was abnormal due to bilateral frontoparietal temporal interictal epileptiform changes. Then this was CBC at our side. WBC counts of 9,000, HB of 9, platelet of 3 lakh. RFT was within normal limit. CRP was 5.3. We have done CSF at our side also. We have done CSF to send NMDA antibodies, and in other hospital for where she was admitted for 7 days, they have sent CSF biofires, which was normal.
How many cells in your hospital?
Was a total 6 cells, a lympho, protein of 18, and sugar of 61. Cultures are negative.
How is the child now?
Seizures are controlled. At our hospital, after the day 2 of admission, she is having no repeat episode of seizure, but fever spikes are still there, but intensity and duration of fever spike has been coming down, but that altered behavior is still there. So psychiatric reference was taken. They have labeled it at some, uh, they have started on haloperidol and some they have labeling at psychotic disorder, but no family history of any psychiatric disease.
Means here, did you do a video EEG? No.
No.
So your EEG is showing continuous epileptiform discharges or it is showing intermittent?
Ammonia 2 values are high, sir, outside.
But
Repeating
outside
here it
ammonia
is normal.
Ammonia is a very, it's a test which is very dicey. You can't just go by one ammonia level. You have to have everything to fit in. So now, forget. I mean, let's look at one by one. What do you all think of the first CSF? 50 cells, 99% lymphocytes.
Viral.
So viral or not even viral is what we want to learn. Why would you call it viral?
Lymphocytic predominance.
Glucose was also 105. No, 105. Glucose normal.
What I'm trying to say is when glucose and protein both are bang normal and you only have a cellular reaction, it's not sure whether even it's a viral infection or it is just pleocytosis due to any inflammatory process, right? So this is a small difference. So bacterial, we want low sugar, high count, all that. But even in a viral, there should be some abnormalities besides just some cells. So first report, 50 WBCs and all of them lymphocytes and sugar and protein normal.
Want to make a point that if CSF is not immediately examined, then the polys are gone. Now you call them lymphocytes. So sometimes there could be a little issue about it, but I agree that this is some reactive meningeal inflammation, which is a result of something near the meninges having inflammation. So that is all that we could give it. So it's unlikely a direct meningitis.
So you are presently treating with anti-epileptics and is under control.
Are under control, but that behavior abnormality is same, no improvement.
She is eating on her own.
Eating, but sleep is disturbed. She's not sleeping. So within 15 to 20 minutes, she wakes up and started shouting in the water. So yes, fever is still.
So when you say 101 spike means like 101 in one
But
day or many?
initially it was 3 to 4 fever spikes, but now it is 1 to 2 fever spikes.
No, Palni, they have not yet got the NMDR result. It is awaited.
Even anti-NMDA looks unlikely in this child. Uh, Typically, anti-NMDA has a fever very short, and then there is an interval which is apparently normal for a day or two, and then comes the whole story. Here, persistence of fever looks very unusual for any of these disorders that we are talking about. Therefore, I wonder, and I want everybody's opinion on that, that fever could be a result of hypothalamic involvement. And that continues, and that doesn't come down even with paracetamol. Here, every part of the brain seems to be involved. So I wonder whether this is a part of a central fever itself. And one way to decide about central fever is when the fever is a little down with whatever reason, then the person looks much better. But here is a child who is behaviorally abnormal, so it may not be easy to go by. But even then, you said it's intermittent behavior abnormality. So that may be a good idea to look at whether the nature will bring down the fever a little, though our paracetamol will not. And, and during that time, the patient looks much better. That rules out almost all the infections.
Have you all noticed that when you give paracetamol, does it help? Or you've not given focused on that? Focus on that. Why we are saying is, as sir said, see, the original illness may be whatever, autoimmune or even that fires or whatever. It has led to hypothalamic damage because of the temperature regulation system going haywire. Fever is now continuing, right? Because obviously there's no infection that so we can see in between child is fine and eating and all that. There's no infection, right? It's not a bacterial CNS infection. Viral infection can't go on for so long. We've discussed the CSF is non-viral, biofaz negative. So it's worth considering whether the fever is due to hypothalamic upset. So one clinical way is 2 o'clock fever, 2:15 you give paracetamol, nothing happens. So check on that and tell us next time.
Autoimmune disorders can also cause high fever. And typically, Rayleigh syndrome, where you don't have a sweating or you don't have tears, you get high fever. And I wonder whether in this hot season, it's only heat fever. And how do you diagnose heat fever? Not fever in summer, right? So heat fever is diagnosed. I think he always keeps on telling us heat fever is diagnosed when periphery and the central part of the skin is equally hot. In every other fever, the fever rises and the periphery becomes cold. That's the way vasoconstriction peripherally avoids heat loss from the body. But that is one. You have been saying it again and again several times.
One month, 1 month, 3 days old, male child, first birth by order, born of non-consensual marriage, resident of Shelu, hailing from Buldana, brought by and informed by mother, reliable, with complaint of cold since 2 days, increased work of breathing since 2 days. Cold was in form of runny nose, and increased work of breathing was in form of increased respiratory rate and depth of respiration. There is a history of oil installation in ear, history of suck rest suck cycle, and there is history of forehead sweating, history of irritability, and history of nebulization in the past. No history of bottle feeding. There is no history of fever, ear discharge, or a loose stool, and no history of reduced urine output or reduced oral intake. There is no previous history of any admission or NICU history. ANC history. There is history of oligohydramnios, which was diagnosed at 9 months of ANC. Birth history. Child is a full term. LSCS was done in view of oligohydramnios. Cried immediately after birth. Birth weight was 2.7 kg. No NICU stay and no neonatal jaundice. Immunization. Received birth vaccine only. Developmentally, child has visual fixation and primitive grasp reflex. On diet history, child is on exclusive breastfeed, accepting adequately. Summary.
So we've always been saying that in a very young infant, if there is a cold, then confirm that cold. Okay. So he has confirmed that it is in the form of a runny nose. So that means there was definitely a runny nose, right? Now, increase work of breathing immediately with that runny nose itself, right? So what are your thoughts on this in a 1 month old child? Runny nose for 2 days, increase work of breathing for 2 days. So same day it started. What do you think?
Presence of cold.
What is odd to call it viral? Mhm. Oh, that is okay. In a small baby, everything is condensed. What is missing? Fever. Everybody is saying now, you should have said pehle se, na? So why should a newborn infant not have fever in an infection? So we've read and heard that, okay, sometimes they can have bacterial infections without fever, this, that. But this, if they have got from, where would they have got it from if it's a viral?
Family member.
1 month family. So you got the history. Anybody in the family had fever?
Yes, sir. The mother actually had some fever before these symptoms in the child.
Mother had fever, cough, cold.
Cough, cold.
Okay. The baby has caught it from the mother. That's a possibility. That contact is very important. Otherwise, baby wouldn't get it like from nowhere. So then you start thinking different things, right? So absence of fever is a bit of a surprise. Then next slide, what did you say? history of oil installation in the ear. So do you think this could be a lipoid pneumonia? Here it is a ear. Come on. Has to be in the nose. Is the ear connected to the respiratory tract? Eustachian tube is there, no? So from the ear, the oil can go through the eustachian tube into the lung. What do you think?
Anatomical angle is usually less. It is usually horizontal compared to in adults, so it can go.
It can go or it cannot go. Answer is not in the angle. Answer is in something else. The tympanic membrane is there, no? Where will the tympanic membrane go? So unless there is a perforated tympanic membrane, how can the external ear oil go through the eustachian tube? Correct. So that is not the cause of lipoid pneumonia. What about history of suck cycle? So what exactly did you ask and what did you get? क्या पूछा?
Mother said there is always, whenever she tries to feed the child, there is forehead sweating only. The child suck for some time and then gets irritable and just does not continue breastfeeding after that. So mother यही बोली कि थोड़ा सा लेता है, फिर थक जाता है, चिड़चिड़ करता है और फिर रुक जाता है और फिर सोता है, फिर से थोड़ा सा लेता
कितनी देर के बाद?
है 5-10 minutes around.
So what again and again we are teaching everyone is that in a primary viral or primary respiratory condition with tachypnea. So suppose this child has this baby has bronchiolitis. Will this baby be able to suck? This baby is breathing 80 times a minute. Will this baby be able to suck? So the baby, mother will say, no, दूध नहीं पी सकता है. Right? As against this, in a cardiac case, what is the history? The effort of sucking makes the baby breathless. Then the baby leaves. Then the baby gains his breath back. हम लोग कैसे दो माला चढ़ के we become breathless, then we sit for 2 minutes, then we are back to normal. And then once the baby is back to normal, baby is sucking again. So you have to try and get this history, then it is suck cycle. Okay. Just ki thoda pee ke chhodta hai is a very vague thing. So you must allow the mother to explain what is happening and then pick up whether it's really suck or whether it's just inability to feed. Understood? Because that will be your differentiation between a respiratory and a cardiac problem. And irritability means what in a breathless child? Very good. So look for hypoxia. It could be hypoxia. Some bronchiolitis will come to the doctor for excessive crying. The mother will not notice that she started breathing fast, the baby. They'll just say, कल से बहुत रो रहा है. And then you have to pick up that it is fast breathing.
Increased precordial activity when voluntarily complained by mother is a strong point in favor of a cardiac problem. The duration is little too short. The baby is just 1 month. Increased work of breathing, she'll understand. But many mothers say कि इधर धड़ होता है. So that is a point because sometimes distinguishing between respiratory and cardiac is not very easy. Presence of significant cough doesn't matter which one, but maybe more in favor of cardiac rather than respiratory, because if it is a respiratory infection which is lower down in the bronchial, see the receptors are maximum cough receptor, the larynx, upper bronchus trachea. As you go more and more peripherally, the cough receptor become less and less, and breathlessness increases. As you go down, cough becomes less and breathlessness increases. While in the cardiac case, cough still remains in addition to that. If there was a persistent cough and a precordial activity noticed by the mother, then it favors cardiac. If there was refusal to suck and fast breathing and not much of cough, then it may favor low respiratory.
Cold is not a symptom of a cardiac disease. So either there is no real cold or the cold has nothing to do with this. But then why cough is due to cardiac disease? Cough is an airway disease. Okay. Where is the airway involved in a heart disease?
That environment becomes conducive for the bacteria to grow due to pulmonary congestion.
You're right. What I want to stress is that left to right shunts lead to pulmonary congestion, but at that stage, the story is not of infection. Story is of cough without fever. When things go on for a long time, then the damage can easily get some organism and becomes an infective cough. So, cough without fever coming for the first time at that age is nothing but a left to right shunt. And cold, you need to. Now, if you ask, sardi hai kya? They'll say, sardi bhi hai. Because for parents, sardi and khasi are together. But here you say running nose. Now, running nose is very unusual at that age. Blocked nose may be.
Forget cardiac, as sir said, but even for a respiratory, it is unusual.
Running nose is very unusual, but blocked nose is not unusual, even in a newborn. Why is that? How can a nose be blocked without so-called nasal inflammation, which means also cold? No? When you have a cold, you have a blocked nose also. But newborns or small infants may have blocked nose, but no running nose or anything. And that's because of the estrogen effect of the maternal estrogen. And therefore, sometimes the newborns may find it difficult to feed, blocked nose, hissing noise, but that is temporary, and the estrogen effect will wear off, and there will be no problem at all. The other thing that you need to watch for really, if there is any nasal symptom, is can there be any nasal abnormality? What kind of nasal abnormality?
Choanal atresia, very good. How will you check?
If it's bilateral, then obviously the baby would be in distress. It'll pass a nasogastric tube.
Correct. And sometimes if it's bilateral, then it's very troublesome.
That will we can use. I remember a baby passed away. Post-mortem, we passed this nasal catheter. It wouldn't go for virus. This baby has bilateral choanal. Choanal atresia, the baby starts crying and does color improves. And then cardiac baby starts crying and color deteriorates. So when he starts crying, oxygenation starts, because then the oxygenation takes place from mouth and not from the nose.
Summary. 1 month, 3 days old, male child, first by birth order, born of non-consensual marriage, complained with cold since 2 days, increased work of breathing since 2 days, with history of suck, rest, cycle, and forehead sweating, with differential diagnosis being severe bronchiolitis or bronchopneumonia with underlying congenital heart defect like VSD. Bronchiolitis or bronchopneumonia. Okay. Then on examination, child was afebrile, a heart rate of 170 per minute and RR of 70 per minute with SCR and ICR, subcostal retractions and intercostal retractions. Peripheral pulses were well felt, central pulses were well felt, extremities warm, saturation of 94% on room air and 99% on O2 by nasal bronchs. AF was at level of 1.5 centimeter into 1.5 centimeter with HGT of 128 mg per deciliter. Anthropometry. Child's weight is 3.3 kg. Expected is 4.5 kg. Falls between -2 to -3 standard deviation. Height of 50 centimeter. Expected is 54.7. Falls into -3 to -2 standard deviation. Head circumference of 37 centimeter. Expected is 40.6. Falls into -2 to -1 to -2 standard deviation. Height to weight ratio is
1 minute. One is they are asking what is the birth weight and the height.
2.7 kg.
Birth weight
weight.
2.7. Birth height we don't know.
No.
Now, head expected you said is 40. That is wrong. 40 cannot be
No,
at
can't.
1 month. So there's something wrong there. Okay.
Yes.
Fine.
On
A small measurement of length in a newborn baby is not easy. Unless you are really very keen, somebody pressing both the knees, the baby must cry when you do that. When you press both the knees, the baby slides down, and then your upper measurement becomes wrong. So measurement at length, you must always take it with little plus and minus.
How do you measure an infant's length? देखा है कभी? Use किया है? You have? Good. Very good. Yeah. So now he said length is 50 and it should be 53. Matlab length is suffered. Matlab it's. So you think this baby has started with malnutrition long back already to affect the baby's length? Normally we say in any severe chronic disease, first weight is affected, then height is affected. So by these measurements, we are saying that height is also affected, which means it's very chronic. Do you agree to that?
So we can't comment if it is chronic, like baby's age is just 1 month. We need to know the birth length.
What I'm asking is, what do you think? Do you think this baby's birth length was, say, 49 or 50, and this baby has not grown anything in 1 month because of that disease? One situation. Or this baby's birth length was 47, and this baby has become 50 in 1 month in spite of the disease. What do you think? You got my question? What do you all think? How long does it take for height to get affected? It takes long. 1 month is too short. So you can't have disease impacting the length of the baby so soon. So what I'm trying to say is that this length at birth must have been not 50, but lesser. And that's why now the length is 50. And you are looking at the normal of 53 for a baby who was born 50. Right? So we are still coming to that.
CVS examination. On inspection, no precordial bulge or opaque impulse, not visible. No visible pulsation, no scars or sinuses. Upon palpation, apex bead palpable in fourth intercostal space, lateral to mid clavicle line. No parasternal heave or no thrill is present. On auscultation, S1, S2 heard. Plus, there was no murmur because there was so much tachycardia. I cannot appreciate murmur. As the child was sleeping, there was a murmur, which was more suggestive of ejection, systolic murmur only. Then on CNS examination, irritable. But
in which area?
like can't be sure, sir, in which area. But after sleeping, the murmur can be heard. Respiratory system, air entry by upper urbanization, soft, non-tender, no organomegaly. So
any retractions? while
Yes, there were subcostal retractions and intercostal retractions were also there.
okay.
So
Still,
no thrill, no thrill.
There's a cardiomegaly or normal heart.
Actually, on X-ray, there is cardiomegaly
No,
evidence.
clinically,
On auscultation,
your apex beat is way out. So there has to be a cardiomegaly. If there is a cardiomegaly, there is a cardiac disease. Okay. And which cardiac diseases may not have murmur?
sir, actually, there was a murmur when the child said.
I get it, because you had not put it there to begin with. I'm asking a question to any one of you.
Pericardial effusion.
So heart defect, congenital heart defect, but no murmur. ASD, very good. But ASD murmur is there, but murmur is missed. Okay. So there is still a murmur, but it's soft enough. And I know one of the doctors who delivered her first baby, and during pregnancy, they picked up ASD in her. So that is right. But the murmur is there, you miss it. But really, no murmur at all. When the defect is so large,
Large VSD.
large VSD, okay, there is no murmur whatsoever. And this child has started very early in life. And therefore, this must be large. And therefore, no murmur still is likely in a heart disease, right?
You said apex was where? Palpable where?
Fourth intercostal, outside the mid cleft. Yes, lateral.
Lateral to midclavicular line. Okay. See, in such a small baby, you have to be very clear of all this, because as sir said, in an exam, if they keep such a case, it will be very difficult to argue what is there in favor of a heart disease, right? The same signs could be there in a respiratory. You are saying
Intercostal retractions were also there.
and subcostal, and then you said even Krebs bilaterally. So it's going to be difficult to say whether it's a respiratory disease or a heart disease. So that heart size has to be as properly judged as possible.
1 month old is too early to come out with left to right side, because pulmonary pressures must come down and then the left to right shunt starts. 1 month is, yes, 1 month is too early. Therefore, if the story is right at 1 month, then I start wondering whether we are missing a mild cyanosis. Okay, is one possibility, because 1 month is too early for any VSD or anything presenting so early. Do you think it could be a PDA that is presenting early?
Could be, sir. Can be there.
So by and large, PDA is largely a preterm baby, as a rule.
And usually PDA murmur is
Yeah.
fairly prominent.
Yeah. Yes. So I was thinking whether you have a good pulmonary circuit, but some mixing occurring, and mixing where a lot of oxygenated blood is getting mixed with deoxygenated, and therefore maybe we are not able to pick up a mild cyanosis. One could have picked up a mild cyanosis on crying if your mother was very observant, but 1 month is too early to have a left to right shunt or cyanotic. Then the next thing is, could it? Yes.
99.
Yeah. So the next thing is, could it be a cardiomyopathy? After all, these are fetal conditions. Okay. Earlier, we used to call it the fibroelastosis. The story starts with probably a viral infection in the fetal life, and the myocardium is involved, and the child is born and then worsens over time. You have restrictive as well as dilated cardiomyopathy. And therefore, if you have, this looks unusual for a left to right shunt. So the thought is, could it be some kind of a cardiomyopathy? That's the next thing. If SO2 is normal, then cyanosis is probably out.
Do you do pulse ox of every newborn
Uh,
before discharge?
before discharge. Not
At
here.
least once before discharge. Or in an ICU? Yes,
We,
but not otherwise. There are some nursing homes where before discharge, as a formality, a pulse ox is done before discharging. It's a good idea because it is very easy to miss cyanosis at that. It's nothing.
So, 1 month, 3 days old male child coming with complaint of cold and increased work of breathing with a history of forehead sweating and circus cycle in birth and developmental normal child is most probably a case of a cyanotic congenital heart disease. And then for the same child, 2D echo was done, which was suggestive of a large 13 secondum atrial septal defect that shunt is left to right shunt. There is mild to moderate right heart dilation, and the main and branch pulmonary arteries are also dilated. No history of pulmonary hypertension or no PDI is present. No. The LV and RV contractility is normal with ejection fraction of 60%. There is no mitral or tricuspid regurgitation. The vascular connections are normal. IVC is normal, and there is left aortic arch. That-
Is there a hepatomegaly?
No, sir.
No
No
hepatomegaly. You have the X-ray of the child on your PPT? No. So ASD is known to present in the immediate newborn period with failure sometimes. Otherwise, then straight it presents in the second decade of life. In between, it doesn't present. But this is after a month, that's a bit.
I think the only one type of ASD, secondum, which presents early in infancy, is one where there is an associated transient myocardial weakness. And then that gets better over time, but not large atrial defect like this. So this is something unusual, okay? And typically secondum defect is often asymptomatic for years old. So to that extent, again, there is no mitral regurgitation to call it an ostium primum, and therefore something odd. But yes, I think in this hall only few months ago, we found a 3-month-old child with Eisenmengerization. I don't know whether any one of you were there, but of course I remember that. 3-month-old child with Eisenmengerization. We have never seen that. But in that, the history given was not right. There was no history of repeated cough. So that history was not given. And at 3 months of age, somebody saw cyanosis. Then, of course, we realized that that repeated cough must have been missed in a history. But echo had shown a large defects which early right to left shunt, which was unusual. I had never seen one at that age. That was the first time we saw. But in this hall only a few months ago, there was an Eisenmenger. So now today we are seeing a large ASD presenting at 1 month of age. Looks very unusual, but medicine is uncertain. Okay, and this proves the fact. But one thing is certain, that we must still find certainty in our behavior, even in uncertain medicine. We can't say anything is possible, so do all tests. We have to be certain to an extent in even uncertainty. And that's how we go. Our whole life is uncertain, but we plan ahead of time. I'll become MD, then I'll become consultant. Okay, uncertainty is there. But these are the ways. I think we will ask our cardiologists whether they have any reason to discuss anything other than that at all. Right?
So this was a little
Abnormality which is not present with ASD and they can be very bad fate. What is that?
EAPVC. EAPVC are of 2-3 types. One looks like a ASD. No, but that is the looks like ASD is clinically, but on echo it will not have that.
In fact, the only thing that looks like ASD is a PAPVC. But the TAPVC comes as bronchiolitis-like picture, but this was bronchiolitis picture. He had put a bronchiolitis, bronchopneumonia, TAPVC, but large, again, we need to be very sure whether you ask your cardiologist that is it compatible with the diagnosis of only ostium secundum defect or there is something more to it, because it looks very unusual.
I was just telling you. X-ray, sir.
This has a cardiomegaly and in cardiac failure. Again, that ASD alone doing, etc. But it could be possible. But I think on all such patients, we should ask to get a better cardiology opinion. And in fact, they would know that they have seen once in a while. Then we cannot diagnose such things really. Do ask your cardiologist, and we will also ask some pediatric cardiologists what is their impression about it, right?
So, I mean, I'm just as students, what did we learn from this case? So, what will you call it, cardiac or respiratory after the whole story? What is in favor of respiratory? What is in favor of cardiac? How will you argue? Because you have very few cardiac findings. So, how will you, in your mind, learn something out of this case? There are no findings cardiac. So let's take it, it's a respiratory. What can it be respiratory? 1 month old with fast breathing without fever. Bronchiolitis. Can it be a pneumonia? Fever is usually always there, and this was a 2.7 kg baby at birth, which means full term proper weight. So no reason why there should be no fever, right? So now, suppose it was bronchiolitis, what all is not fitting in? I want you to keep thinking like this because it's going to be a difficult case in the exam to say why is it cardiac. So if it is bronchiolitis in a 1 month old, what is not fitting in? Which is a feature of bronchiolitis. Bronchiolitis breathes very fast, 70, 80.
Poor sweating prior to the even present prior to this symptoms.
That you'll have to ask. So what she's saying is that this heavy breathing started, let's say, yesterday. But before that, whether there was suck cycle. So did you get that history?
Yes, there was forehead head sweating also before this
Even
symptom.
in the first month.
Even in the 10 days life only.
So that you didn't mention.
Only the moderate right-sided dilatation, including pulmonary artery. That means there is a flow, excessive flow into the pulmonary artery. There should have been an ejection system.
Yes, Marmaro.
And I think that goes well with that.
One is that history. What else? What do you think? What doesn't fit in bronchiolitis from what you have been told to you? Very good. So saturation was what, 98, 94. So that is a little odd for bronchiolitis. Bronchiolitis usually will have a little less. So keep thinking like this.
Cardiomegaly, if detected.
Of course, cardiomegaly, you have to be very, because it's a small baby, small chest, every 1 centimeter counts. So you have to be very accurate. Where is your apex beat? And you said apex impulse was not seen. So it was all going by your feeling of the apex beat. But that, so as sir already said, cardiomegaly, that is important. So these are 2, 3 small points that you'll have to hold on to call it cardiac and not respiratory clinically, right?
Next time in an exam, don't call it ST. Okay, because it will not be acceptable to disease very much. But these are rare situations. So, uh, but if asked further, can ASD come up early? Then you say, I've heard once. That is all, right? Mostly examiner won't ask because most of us have not seen ASD at that age. So very likely, but we will remember only those things. So we will tell an examiner, no, no, and he'll say, no, no, you're talking nonsense. So I think take care of it. Okay, rare things should not be mentioned. Yeah. You want to say something?
Any other respiratory conditions can come at 1 month with tachypnea without fever.
The baby has been on ventilator or a preterm baby, then a BPD. Then.
Bronchopulmonary dysplasia, but that baby would not settle the tachypnea right from that newborn period, correct? There was newborn period also problem and that tachypnea continued. Anything else? Okay, aspiration pneumonia. So something else? So tracheoesophageal fistula, congenital abnormalities which cause aspiration. Anything else? At birth, the baby was okay, and then there is tachypnea which has started.
And it's gradually progressive. So
Without fever.
Reflux.
Why should reflux cause tachypnea? We are talking of respiratory conditions. I gave you the clue.
does pyloric stenosis present at birth? May present rarely, but mostly not. But it's congenital. Then why does it present at 4 weeks, 6 weeks? If you tell me that, then I will ask you what can be the similar things in respiratory care. And the reason is there is a pulmonary, there is a pyloric stenosis. It's not atresia. So some milk goes on, but some milk remains inside. When that milk remains inside, there is a chemical inflammation, and that pylorus becomes more and more obstructed, and that takes few weeks. But rarely it would be even at all. Now, similarly, here is the pylorus. That means there is a food pipe, but there is an air pipe, wind pipe, right? So, could any disease of the wind pipe slowly progresses to cause breathless? And the answer is congenital lobar emphysema. And why one lobe causes breathlessness? People can live with one lung. There is 1.5 lungs.
So what is emphysema? Air trapping. So what will happen to that part of the lung? Other parts it will press. That part will become bigger.
So typically a left upper lobe getting emphysematous more and more compresses the left lower lobe also. And then half the lungs are gone, then the baby starts getting more and more breathless. Okay.
Just to keep everything like you keep you thinking any other cause of fast breathing at 1 month of age, which is now without fever, which is non-cardiac and non-respiratory? To keep thinking of all, na? Fast breathing isme this child had as the presenting complaint. Excellent. And due to IEM or RTA. So depends, no? Depends on the severity and all that. So think of acidosis also without any losses. So this is not a hypovolemic, but some metabolic problem, right?
The tachypnea is different.
Ah.
That tachypnea is deep. Tachypnea, this is fast breathing with that. The tachypnea is deep and will take little time for you to appreciate. Unless you count the RR, then you will realize that obvious distress is not. There's tachypnea, but not so much of distress. Diaphragmatic hernia is another thing that you may think of. And when will you suspect diaphragmatic hernia? When there is, let's say, dextrocardia and the abdomen is flattish, especially if it's on the left side, then the diaphragmatic hernia here and the heart has. Anytime when there's a dextrocardia, look at the abdomen and see if it is flat or whether it is bulging.
Any questions? Anything that you all didn't understand in today's case? Anything on investigations, management? Okay. So we meet next Thursday.
Sir,
Anything from the online audience? Sorry.
Sir, whenever
Thank
we
you.
have
Thank you,
a
Amdekars sir, and
2-month-old
everyone for a wonderful learning. Thank you very much, sir.
Okay. Thank you.
whenever we had a 2-month baby presented here or out there, there's been either a CNS case or a cardiac case. Otherwise, usually no other.